The topic of this presentation is TBI in infants. Traumatic brain injury in infancy is relatively common and is known to lead to poorer outcomes compared to injuries sustained later in life. These outcomes, which may not be all apparent until the child begins to mature, include cognitive communication deficits as well as swallowing, behavioral, and sensory motor issues. One known critical factor affecting the child's outcome following TBI is the age of the child when the injury has occurred. Research has shown that infants are especially vulnerable to TBI due to the fact that their brain is still developing. SLPs play a role in these patients' treatment across their lifetime. However, in acute care, SLPs provide specialized treatment which incorporates assessment of prelinguistic factors, monitoring trends, and counseling family members. Traumatic brain injury is caused by an external force such as a blow to the head, an object penetrating the skull, or rapid acceleration and deceleration of the brain within the skull. The whole spectrum of traumatic brain injury, from mild to severe, can cause cognitive communication issues. These effects on TBI in the infant and toddler population are often not recognizable right away. This is because they can continue to emerge as the child becomes an adult when they are faced with greater expectations for learning and behavior. Survivors may later manifest developmental delays, sensory deficits, feeding difficulties, recurrent seizures, intellectual deficits, motor impairments, attentional deficits, and/or educational and behavioral deficits. TBI is the leading cause of death and disability in children and adolescents in the U.S. This has also often been called a silent epidemic by researchers because of the lack of public awareness about the scope of the problem. And there are two at-risk groups, 0 to 4 and 15 to 19, with boys being more affected within both groups, and the children between 0 to 4 being especially vulnerable to TBI. And TBI in young children can either be inflicted or non-inflicted or accidental. Inflicted brain injuries are caused by the child maltreatment or child abuse, and this includes things like shaken baby syndrome. And non-inflicted or accidental brain injuries include things like motor vehicle accidents and falls. And research has shown that most inflicted traumatic brain injuries occur in children less than 2 years old. And these developmental outcomes for the children who survive inflicted injuries may be worse than those of children with non-inflicted injuries. So one aspect that can affect the outcome following TBI in infancy is the age of the child when the injury occurred. There's a traditional view that younger children fare better after a brain injury compared to older patients, and they may be better able to recover. And the reasoning behind this is that younger brains are more plastic or are better able to recover after injury and are so-called bounce back. However, research shows that the younger the child at the time of the injury, the greater possibility of long-term developmental challenges. This is because, unlike in adults, an injury to the child's brain affects an organ that is still developing. However, the relationship between age and outcome is not necessarily a linear one. Some researchers have suggested that there's a critical period for when the brain is most able to compensate for the effects of the injury. These critical periods vary from 1 to 2 years old and to 1 to 5 years old. But in consideration of the complex relationship between age and outcome, infants under 1 year of age are at the greatest risk for poor outcomes following TBI. This is because they're more likely to suffer diffuse injuries because they have not yet reached the critical age suggested for plasticity, and they're at their earliest stages of brain maturation. Another thing we must consider when working with infants and toddlers in this population are the developmental challenges that may present themselves as the child grows. The developmental stages and challenges that can occur after TBI are often overlooked because of the misguided belief that if the child looks okay, then they must be okay. And because of this, the connection between the communication, educational, and behavioral problems is not often made to the previous TBI. And also, the full impact of the brain injury occurring in a young brain may become evident over time as the brain fails to mature at the same rate as other children. And these children actually may recover previously developed skills in early developing basic cognitive functions such as memory and vocal acquisition, but new learning will be difficult for these children. So, because the child may later developing challenges, it makes it very difficult to determine the outcome of a young child with TBI. This is because children develop over time, so some outcomes may not become apparent for many years post injury. For example, damage affecting the literacy skills may not be noticed functionally until the child is expected to learn to read. And this is particularly difficult for infants, as many of the skills that might indicate so-called good outcomes would not be expected in a child so young. And another thing to consider is that we're not able to assess the premorbid functioning to use for goals. This is because, once again, the premorbid situation is not clear in children, especially infants. So, as far as the actual injuries, there are two primary types, non-penetrating and penetrating. Non-penetrating is brain damage due to the indirect impact without entry of any foreign object into the brain. And penetrating injury involves an open wound to the head from a foreign object, typically marked by focal damage, that occurs along the route of the object which traveled into the brain. And another thing to consider is the mechanism of injury, or what was the cause of the injury. And some of the most common causes in young children are motor vehicle accidents, falls, physical assaults, or child abuse, which is most common in children in infancy. And also, as I mentioned before, injuries can either be inflicted or non-inflicted. So when it comes to the structure and physiology of the brain, there are particular patterns of injury as seen in children depending upon their age at the time of the injury, as I mentioned before. And the injury profiles in infants have been found to be different compared to older children. This is because their brain is undergoing rapid development, also because they have thinner skulls, which are easily deformed by external blows and pressure, which results in a higher rate of skull fractures. So there are several types of major injuries. The first one is a hematoma. A hematoma is when blood collects or clots when a blood vessel ruptures, and this clotting can cause pressure to build inside your skull. And the most common type of hematoma is a subdural hematoma. This is when the blood collects beneath the dura mater, causing the cells immediately under it to drown out and pushes pressure down onto the cortex. And another type of hematoma is an epidural hematoma. And this is when the blood collects between the skull and the dura mater. And because it's right up against the skull, the more blood that there is, the more downward pressure that there is. So this typically, kids don't typically fare as well with this type of hematoma. And another type of injury is a hemorrhage. And a hemorrhage means that there's uncontrolled bleeding. And the two most common types of hemorrhages associated with TBI for infants are subarachnoid hemorrhages and retinal hemorrhages. A subarachnoid hemorrhage is when there's bleeding into the space that surrounds the brain, and a retinal hemorrhage occurs when there's bleeding within the retina. And these two types of hemorrhages occur most often in infants when they are violently shaken, which is known as shaken baby syndrome, which causes a forceful rotation and acceleration of the head and extremities. And this acceleration and deceleration of the brain that occurs creates shearing forces, which can cause diffuse axonal injuries. And a diffuse axonal injury, which is also known as a shear injury to the brain, damages the brain cells when the brain moves rapidly within the skull. And infants are more likely to sustain a severe diffuse lesion than older children because they have an open fontanelle, which can absorb the impact of the injury. Also because they cannot support their head during the time of the injury, and they're more likely to sustain a TBI from abuse than a localized impact as an older child would. So because no two cases are alike and TBI can cause injury all over the brain, depending on the type of injury it is, the symptoms may vary slightly person to person. However, across the range of childhood, many short-term and long-term deficits in motor, cognition, language, and behavior have been documented following TBI. And as for speech, there may be expressive and receptive language deficits down the line, as well as language organization and discourse difficulties. And for speech, dysarthria may be present. And dysarthria is a motor control or muscular execution for speech that can affect the intelligibility of the speaker and result in communication breakdown. And some other general speech characteristics following a TBI may include reduced breath support, reduced volume, monotone pitch, imprecise phonemes, and hypernasality, as well as prosody issues. And TBI in infancy can also affect a child's feeding and swallowing. There can be general feeding difficulties as well as the presence of a reduced attention and impulsivity during feeding times. And dysphagia within this population is most commonly seen as abnormal tongue reflexes, poor jaw stability, labored or inefficient chewing, impaired lip seal, reduced overall eating efficiency. And also with dysphagia, the child is at risk for aspiration, which can cause pneumonia. And these swallowing and feeding issues may be a result of a behavioral issue, but they can also be caused from being tubed or ventilated in acute care for too long. And without using these functions, it can lead to sensory and motor issues for eating down the line. So, as for the effect on behavior, which I feel may be the most obvious initial signs following an infant TBI, you may see disruption in regulation of sleep wake patterns, inhibition and impulse controls, seen through temper tantrums, unpredictable emotional reactions, as well as self injurious and self stimulatory behaviors. And in the long term, research has found that these children may be more likely to develop psychiatric disorders, ADHD and depressive disorders being the most common, and also there may be inappropriate social behaviors seen once the child begins to develop further. So, the cognitive issues are one of the most prominent consequences of brain damage, and as previously mentioned, they can affect the infant who suffers from brain damage, whether mild or severe. And these cognitive issues you may see after a TBI in an infant could be working memory deficits, attention problems, auditory awareness processing issues, and seizures. And long term, the child may have deficits in problem solving, reasoning, and other executive functions. And finally, the child may also experience sensory and motor issues. There may be deficits in visual and hearing. There may be spatial disorientation, fine motor skill deficits, and movement disorders or spasticity. So, as I mentioned in the literature review, it can be difficult to predict the outcome measures and determine the pre-morbid functioning levels of these patients. However, knowing that the expected developmental deficits are to come, SLPs can focus their assessments on pre-linguistic things that may be signs of language problems. And although I was not able to find evidence regarding the SLP's role in acute care, based on my background knowledge, I would focus my assessment on things that can lead to language problems such as sensory motor integration, joint attention, auditory awareness, and my assessment would include things such as parent interviews and inventory scales. And then as for counseling, the family may have difficulty coping with the sudden injury, so we would want to counsel the family and make sure they understand what's going on. And lastly, we would need to monitor the patient's trends periodically by reassessing the patient's um, progress over time because they can progress rapidly and slowly, but we want to monitor them, make sure they're progressing in the right direction. So, in summary, this talk was concerned with TBI in infancy. We discussed how TBI in infancy can, from mild to severe, can cause cognitive communication difficulties, and the younger the child at the time of the injury, the greater the possibility for long-term effects, and the fact that these deficits may not be apparent until the child begins to develop. We also discussed how there are several different types and causes of TBI in infancy, and that infants are more likely to sustain a TBI from abuse than older children. And lastly, that TBI in infancy can have long-lasting speech, language, swallowing, cognitive, and behavioral deficits, and that SLPs in the acute care play a role in assessing, diagnosing, monitoring, and monitoring the patient as well as counseling and educating the family. So, on a final note, one thing to consider is that the family concern can have a large impact on the child's educational and social development. The burden of the injury on the family members and caregivers is great and particularly important for these people because they are the ones providing long-term support and care for these children. So emphasis should be placed on the need for a prolonged follow-up into the school years and probably even the adolescence years because these consequences of infantile TBI can be fully appreciated once they get to that age. And these are my references.